Mohandas sir, start cheyano sir, adu wait cheyano. Good evening, Jayaraman sir.
Good evening, good evening, good evening.
Sir.
Good evening, Jayaraman sir.
Good evening.
Srinivasan sir, good evening.
Good evening,
Srinivasan
sir.
sir. Srinivasan sir, good morning, good evening.
Good evening. Wish you happy Teachers' Day. Just now I finished my typing and sending you. Jayaraman sir. Nice. Yeah. Just I was typing. Yes.
Happy Teachers'
I
Day.
have put it in the chat box. It is apt. I learned a lot from this platform.
Good evening, sir.
Good evening, Susan. How are you?
Fine, sir.
Good evening, Susan.
Good evening, Jayaraman. Yeah.
Krishna boy, Purushottam and all, they haven't come.
Purushottam sir told he will be late by around 10 minutes.
Okay, yeah. So really, sincerely, I thank all of you for keeping my mind a little more active in a far off place. Thanks for this webinar. Otherwise, I would have missed all these things. Dr. Ananthakeshavan sir, all the best. And for this coming few months, very important for you. Happy Teachers' Day, Ananthakeshavan sir.
Happy Teachers' Day. Mohandas, good evening.
Good evening, good evening.
No, Jayaraman sir.
Good evening, and
Very nice seeing Jayaraman sir after quite a long gap. Probably he was watching it, but this thing in the platform, I didn't see him.
Uthup madam, good evening.
And good evening, Ananthakeshavan sir.
Somebody talking about you in Jaipur. I was Jaipur the day before yesterday.
Jaipur. Yeah.
Yeah, in Delhi. I
Yeah.
think.
Long
Yes,
time.
Eh?
Long time. It's a long time.
Means, I was there in Delhi day before yesterday. So we discussed about nephrology department. Then we are talking about you also. Good words, not bad.
It's okay.
Pediatric nephrology, who was there?
Who was there?
I visited
She has been doing a great job. I have been, right from her beginning days, I have been watching her progress. Remember, I have come and visited in your place.
Thank you, sir. Yeah, it has been a long 14 years.
Mohandas sir, start cheyidalo sir.
Start here.
സ്ഥിരം പാർട്ടിസിപ്പന്റ് കാണുന്നില്ലല്ലോ.
വരും സർ. പുരുഷോത്തമൻ സർ അല്ലേ? ഡോക്ടർ അരുൺ ഒന്ന് സ്ക്രീൻ ഷെയറിംഗ് ഒന്ന് സ്റ്റോപ്പ് ചെയ്തിട്ട് പറയാമേ. എപ്പോഴും സ്റ്റാർട്ട് ചെയ്യുന്നത് പറയാം. സ്ക്രീൻ ഷെയറിംഗ് ഒന്ന് സ്റ്റോപ്പ് ചെയ്തിട്ട് ഓക്കെ. മൂന്ന സർ തുടങ്ങാണ്. So, very good evening to one and all. And on behalf of IAP Thiruvananthapuram, we invite all of you to this flagship program, State Presidential Action Plan 2024, PG teaching program that has been hosted by IAP Thiruvananthapuram. And we have a very interesting case for today. So, before we start the session, I would like to call upon our State President, Shimi Paulo sir, to give the keynote address. Shimi sir. I think Shimi sir is not there. So next, I would like to call upon our IAP Trivandrum President, Hariprasad sir, to speak a few words. Over to Hariprasad sir.
Thank you, Venu. I have at the onset a very, very happy Teachers' Day to all my dear and respected teachers. And I think it's really happy. We have got almost all the leading pediatricians and teachers today. And I'm sure this program will be an excellent program. And I wish this program all success. Thank you.
Thank you very much, sir. Next, I would like to call upon our scientific convener and our beloved Anindya Keshwan sir, who's contesting for National President, to speak a few words. Over to Anindya Keshwan sir.
Very good evening, respected Presentor President Dr. Gari Prasad, Program Convener Dr. Mohandas sir, Past State President Dr. Jayram, Past State President Dr. Jayram sir, IAP Thiruvananthapuram Secretary, very active Secretary Bino, and our senior teachers of teacher Dr. Srinivasan sir, my dear friends. Also, I'd like to wish you all very happy Teachers' Day of a student here. And I would like to congratulate both IAP Thiruvananthapuram and also state level Dr. Mohandas for conducting the program without any interruption, very actively and with very great enthusiasm. And also today we are likely to have a nephrology case discussion. I think usually we used to discuss neurology and cardiology alone. I think it's a good attempt to have a nephrology case discussion. I wish program all success. Jai Hind, Jai IAP.
Thank you very much, sir. Next, I would like to call upon our IAP State PG Teaching Coordinator, Mohandas sir, to speak a few words.
Happy Teachers' Day, teacher of teachers, Srinivasan sir, and all the teachers in this group. This week, Trivandrum IAP is organizing this program, and office bearers of IAP Trivandrum, Dr. Hariprasad, and Ben have done a wonderful job. And today's case discussion is being led by none other than Dr. Susan Uthup, who is leading the Pediatric Nephrology department in SATH.
I'll mute everyone. Mohandas sir, unmute.
And I would like to wish all the success to this program. Thank you.
Thank you very much, sir. Next, I'd like to call upon Jayaraman sir to speak a few words.
Good evening. Thank you, Benno, for this opportunity. I'm really, really appreciate the effort taken by Dr. Mohandas and Dr. Chimmy and his team in conducting this PG teaching program as a regular event. This will create the interest of our postgraduates in IAP activities also. I wish this program solve everything that is good. Actually, I am very happy to see a nephrology case discussion today. Thank you for this opportunity.
Thank you, sir. Next, I would like to call upon our IAP Trivandrum PG Teaching Coordinator, Priya Srinivas Madam, to introduce the chairperson and mentor, and then we'll start off with the session. Over to Priya Madam.
Thank you, Benno, for the opportunity. It is indeed a pleasure to see all teachers, and actually students make us teachers. So it's like both sides of a coin. So this is a great gathering with teachers and students. So I'd like to welcome and introduce Susan Uthup Madam, who is the faculty today. As we all know, Susan Uthup Madam is a well-known pediatric nephrologist. She is also a great teacher, academician, and a clinician. I welcome Madam, and we have mentor, Dr. Christy. She is also working as assistant professor in the Department of Pediatric Nephrology in SATH Hospital, Trivandrum. I welcome her. And we have Dr. Arun Kesav, who is our own postgraduate student. He is JR3 of Department of Pediatric Society Hospital, Trivandrum. I welcome you, Dr. Arun Kesav. So I think we'll start the case discussion. Okay.
Thank you.
We'll start with Dr. Arun. Okay.
Okay, Arun, screen sharing ചെയ്യാം.
Full screen, Arun. Unmute, please, unmute. Is he audible, Benno?
ഇല്ല മാഡം, അരുൺ ഓഡിബിൾ അല്ല. ഐ തിങ്ക് വോളിയം ഇച്ചിരി ഒന്ന്.
No, you are not audible, Arun.
അരുൺ ഓഡിബിൾ അല്ല, കുറച്ച്.
We can see your screen. Please make it full screen, and you need to be audible also.
അരുൺ ഇപ്പൊ മ്യൂട്ട് ആയിരിക്കുകയാണ്. അരുൺ കേശവ് മ്യൂട്ട് ആയിരിക്കുകയാണ്. വീഡിയോ ഒന്ന് ഓൺ ചെയ്യാം. ആൻഡ് വോയിസ് കുറച്ച് ഫീബിൾ ആണ്, കേൾക്കുന്നില്ല.
Some problem with your audio.
Hello, sir. Hello, sir.
ഇപ്പം കേൾക്കുന്നുണ്ട് അരുൺ, ഇപ്പം കേൾക്കുന്നുണ്ട്.
Yes, sir. Shall I share the screen, sir?
Yeah. Full screen ആക്കിയിട്ട് we'll start.
Yes.
അരുൺ വീഡിയോ കൂടെ ഒന്ന് ഓൺ ചെയ്താൽ കൊള്ളായിരുന്നു, ഇൻ കേസ് നെറ്റ്വർക്ക് ഓക്കെ ആണെങ്കിൽ. ഫൈൻ. ഇപ്പൊ ഇനി ഒന്ന് ഫുൾ സ്ക്രീൻ ആക്കിയാൽ മതി. കേൾക്കുന്നുണ്ടോ?
Yes, sir. Yes, sir. So, കാണാമോ sir?
Okay, no problem.
Yes. Yes, sir. Good evening, everyone. First, I would like to thank IAP for giving me this opportunity, and happy Teachers Day to everyone. And I am thankful to my teachers and for presenting on this Teachers Day. We'll start seeing the case. Madam, shall I start, madam?
Yes, you can start.
Yes. This is a 10-year-old female child. This date of birth is 17/5/2014. Date of examination is 30/8/2024. They are coming from Marthandam, Tamil Nadu. Informant is mother. She is reliable. And child was under nephro follow-up and came last week. And their chief complaints were inadequate weight gain noted from 3 months of age, increased frequency and amount of urination noted from 3 months of age, and delay in attainment of milestones noted from 1 year of age. Since the events of the child started from the antenatal period, I would like to start from antenatal history. Shall I proceed, madam?
Yes.
Yes. Antenatal history. This is a second child. First child is it was a new sibling death was occurred. I will describe. It was a preterm child, 1.2 kg. It was delivered at 36 days of life. I will describe in detail in family history. This is the second child. Age of mother during conception is 30 years. Age of father is 33 years. They were initially registered in private hospital. And first trimester, they were after 45 days of missed period, they confirmed pregnancy by urine pregnancy test. First trimester was uneventful. There was no history of any fever with rash or drug intake, no history of any burning micturition, no history of any hyperemesis, no history of any bleeding per vaginum, no history of any radiation exposure, toxins or other medication history. Dating scan was done, which was normal. And coming to the second trimester, mother was found to have hypothyroid and was started on levothyroxine. No history suggestive of any gestational diabetes mellitus, no history of any gestational hypertension, bleeding or leaking PV. Anomaly scan was taken, which was normal. And mother felt quickening at 5th month. And during 6 months, mother noticed to have polyhydramnios and no history of any blurring of vision or limb swelling. And iron and folic acid was taken, and TT was also second dose taken. And the third trimester, fetal movements are well preserved and progressive. No history of any UTI or decreased fetal movements. Iron and calcium supplements were continued. Other scans were normal except mother had polyhydramnios. And coming to the birth history, it was a term baby. Normal vaginal delivery, birth weight was 2.2 kg. Child cried soon after birth, and breastfeeding initiated within 1 hour of life, and urine and meconium passed within 24 hours of life. And postnatal child was discharged on postnatal day 3. No other significant events. And
Okay, Arun, you were talking about a baby who is not gaining weight and noticed from 3 months of age, and there is history of polyhydramnios. So what are the causes for polyhydramnios, and when will you say that there is polyhydramnios?
Polyhydramnios, madam, by measuring amniotic fluid index, it should be a single pocket should be more than 8 centimeters, or measurement of 4, average of 4 should be more than 25. And causes of polyhydramnios, because of either there should be swallowing defect or there is increased production. That is, swallowing defect may be due to any duodenal atresia, esophageal atresia, or any myotonic dystrophy. There can be swallowing difficulty. Or in case of in case of twin pregnancy, polyhydramnios can happen. And in case of when child is having more frequent urination, that is in case of Bartter syndrome, polyhydramnios can happen. Or in case of neural tube defects like aneuploidy, polyhydramnios can happen.
Okay, so what are the complications of polyhydramnios that may occur?
Because of polyhydramnios, there can be preterm vaginal delivery can happen, madam. Chance of infections are there, and mother is not able to appreciate fetal movements well.
Okay. Okay, good. You proceed now.
Madam. And after that, child was on exclusive breastfeeding. During 45th day vaccination, birth weight was 2.2 kg, and during 45th day vaccination also, child had weight of 2.35 kg. Child was on exclusive breastfeeding. During that time, mother told that they were on only exclusive breastfeeding. They didn't went to any hospital. 3 months of age, a child had.
Arun, this weight at 45th day, 2.35 kg, will you be satisfied?
No, madam. At 45th day, it should be more than, it should be 1 kg should have increased. And ideally, they should have shown to the hospital. And it has to be evaluated during that time itself, madam.
Okay, so at this point itself, the first postnatal assessment that was done, Yeah,
Yes,
this
madam.
45th day, this baby should have been getting some more evaluation to assess for poor weight gain. So that was not happening. Okay.
Yes, madam.
Okay. Continue.
Yes, ma'am. At 3 months, child had loose stools for 2 days and vomiting. It was transient and followed by 1 episode of rolling of eyes with paroxysmal activity, which is suggestive of seizure. No history of any fever, trauma, or no other bleeding manifestation. And child was admitted in local hospital. During hospital admission, mother told that mother was noticed there was increased amount of urine frequency of urination was there, and mother used frequent diaper change was history was there, and diaper was heavy and leaking during every time. And according to mother, child was underwent some investigation which showed some electrolyte abnormalities, and a child also had some low blood pressure, and for which the child was treated with IV fluids. And during that time, blood sugar was normal, and child treated with IV medications initially for 2 days. Later changed to oral medications. Mother told after 2 to 3 days, child becomes symptomatically better. No further loose stools and vomiting after admission, and child was discharged on some oral medications.
So at this point, what you would have done? Like there are so many pointers that are there, which is actually pointing to something that is abnormal. So what will be your thought process at this point?
Yes, madam. Child is having failure to thrive and some sort of loose stools and vomiting, and there was no there was polyuria history was there.
What do you mean
At
by
this
polyuria? How can you be saying that this baby is polyuric?
Ideally, it should be, madam, but based upon history, I assumpted usually it should be more than 2 liter per meter square, or more than 600 ml per kg per hour in infancy. If it is more
600
than
ml. 600 ml per kg per hour. What do you mean? 600 ml.
More than
You want to change?
61.
No, 6 ml. 6 ml.
Sorry, 6 4
ml.
more than 4 ml per kg per hour if it is more than 1 year.
More than 4 ml in children and more than ml per kg per hour in neonates. So this baby, it was already past the neonatal time, no? So
yes,
ideally the urine should have been quantified. So that was not happening. But the history is very classic, like diaper was very heavy, leaking every time. And the baby must have received ORS, but he is requiring IV fluids. This time IV fluids was given and IV medications were given, changed to. And then the baby is symptomatically better, but no documentation of whether the weight gain was there and what was the electrolytes, and all those things are not there in the documents. Okay, we will proceed now.
Yes, mother told that child was on some follow-up initially, and they were taking some oral medication. At 6.5 months of age, child again had vomiting for 2 to 3 episodes and 1 episode of uprolling of eyes, and was admitted in local hospital. And mother told the child was ventilated for 3 days. Mother doesn't remember the exact reason for ventilation. At the time also, no fever, no irritability, or no any respiratory symptoms like cough or rhinitis, no history of any floppiness, no history of any difficulty in moving hands or legs. And at the time also, child was treated with IV fluids. And on that time, blood investigation showed some electrolyte abnormalities. And this time also, after treating with IV fluids, child became better, and the IV fluids was changed to oral, and was discharged on oral medications. Initially, they were under follow-up initially, but later they lost to follow-up.
Any documentation of the weight at 6.5 months?
Yes, madam. At 6 months, it was 3 kg, madam. At that time also, weight was not doubled.
So the clues that are there are, one is polyhydramnios, the other is polyuria, and then developing seizures, vomiting. So what do you think? What are the possibilities that you will be considering? Do you think this child's failure to gain weight is due to organic causes or whether it is due to this other spectrum that is non-organic?
Madam, it should be.
So how was the feeding? So you were telling that the breast milk was adequate and mother was feeding well.
Yes, madam.
No, but the baby was not gaining weight. So do you think
Yes,
it
madam.
was non-organic, it is non-organic causes or organic cause for failure to thrive? What are the clues that will be there? So let us not think straight away to renal causes. Let us see in a broader way.
Yes,
What
madam.
are the red flag signs which will suggest that there is an organic cause for failure to thrive?
Madam, inadequate weight gain and vomiting and loose stools. And
what was the color of stool?
Stool was
yeah.
Yes, madam.
Yeah, see.
Stool, it was normal color only, they told, madam. It was not any pale colored or high
So
colored urine.
at this point, we will have to think whether this baby is having major organ system abnormalities or diseases, which can be starting from the gut, because you are telling that there was vomiting and loose stools, and with which the baby was getting hospitalized. So it could be a disorder that is there affecting the GIT, and there is polyhydramnios also, or it could be a cardiac disease or a liver disease, or it could be a respiratory system problem, or it could be involving the kidneys and the urinary system. So we will have to really look at all these organ systems to say whether what is the real issue. So what are the negative points that would be helpful at this point? If it is gut that is involved, what will be the feature that will be there? And what are the possible causes for GIT as a cause for FTT?
Yes, madam. GIT, there can be malabsorption syndromes, madam, malabsorption syndromes, or there can be any congenital chloride diarrhea, or because of cystic fibrosis, they can have chronic diarrhea because of pancreatic insufficiency. And for cardiac causes, there was no history of any no history of any cyanotic spells or bluish discoloration of lips was there, madam. So there was no history of any chronic diarrhea. It was loose stools was just transient. It was not chronic, madam.
Okay, so the major red flag sign that is there is here, increased urine output, irrespective of having even
Yes,
when
madam.
the baby is having an extra renal loss that is there as vomiting and diarrhea, the baby is still passing lot of urine. So what are the causes of passing lot of urine? What are the different causes that we will be considering? Or what are the diseases involving the kidneys that can produce high urine volume?
We should consider some inherited tubulopathies, madam. We should consider renal tubular acidosis. We should consider Bartter syndrome. We should consider nephrogenic diabetes insipidus also. Can be either central or nephrogenic. And Bartter should be considered, renal tubular acidosis should be considered, and diabetic insipidus should be considered, madam.
So do you consider congenital anomaly of kidney and urinary tract also?
Yes, madam.
So what are
yes, madam. Yes.
Yeah, what are the congenital anomalies of kidneys and urinary tract which can present with polyuria? Any hypodysplastic kidneys?
Yes, madam.
Okay, even this is a female child.
Yes,
so
yes,
if it is a male child, you will be thinking of obstructive nephropathies, which can also affect the renal concentrating ability and produce polyuria.
Yes,
okay, cystic kidney diseases. So there are, so when you think about the renal cause of polyuria and failure to thrive, you have to also discuss about the congenital anomalies of kidneys and urinary tract, which can affect the concentrating ability, obstructive refluxing anomalies of the kidney, which will be associated with recurrent urinary tract infections. So those are the polyuria, red flag signs that you will be considering, which will be pointing to the renal as the FTT, this kidney disease as the cause for FTT. So you are not talking anything about the whether there is a history of UTI, whether it is there or not. Okay. So that is also important.
Okay.
And now you can proceed.
Yes, ma'am. And after that, child was lost to follow up. And at 2 years at 2 years of age, child came to SAT for evaluation. And child at that time also complaints was inadequate weight gain and increased urination. That is usage of more number of diapers. And at that time, increased thirst also was present. And mother told that child used to drink more water during the winter season also. And child had developmental delay and child attained social smile at one. Mother told child attained social smile at 1 year only, and head control was attained at 9 months. And child was able to sit without support, and not able to stand, and child was able to tell monosyllables at 2 years of age only.
Okay. So there is definitely developmental delay. And do you think it is more of gross motor?
Gross motor is more.
Yeah. So what could be the reason for gross motor delay much more than?
Because of the chronic electrolyte disturbance.
Yeah, very good. So chronic electrolyte imbalance could be, and recurrent, definitely there was recurrent hospitalizations. And
Yes,
this
ma'am.
baby was taking a lot of fluid, and so there was actually the solid food that the baby was getting was also less. So possible malnutrition also. All these factors will be contributing. So let us proceed.
Yes, madam. And at 2 years, there was no history of any bony changes or deformities noticed by the mother. No history of any floppiness or difficulty in moving limbs, or no history of any spasms like episode or cramps. No history of any chronic diarrhea or recurrent respiratory infections or recurrent fever. No history of any constipation. No history of any salt craving like episodes was there. No history of any abnormal odor or smell. No history of any loss of attained milestones, and no history of any visual disturbance was there.
So at this point, just go back to the slide.
Yes,
you
madam.
discuss why you are taking each of these negative histories.
Yes, madam. And there was no history of any bony changes, because there was history of polyuria and polydipsia. In renal tubular acidosis, there can be associated rickets associated, madam. So that history.
What is the triad of CKD in a child? What is the triad of kidney disease in a child? Triad.
Madam, anemia, short stature,
and bony deformities.
Bony deformity. Yes.
So bony deformities is not pointing to rickets alone, but it may point to a CKD also.
CKD.
Okay.
Yes,
so there was no history of bony deformities. That is very important. The next point.
No history of any floppiness, because of the hypokalemia, there can be tone may be reduced, or difficulty in moving limbs. I would like to consider paralysis because of hypokalemia. No history of any spasm like episode for hypocalcemic tetanic like episodes. And no history of chronic diarrhea in case of cystic fibrosis, and recurrent infections in cystic fibrosis. Recurrent fever because of dehydration induced fever.
No, not only recurrent, not only dehydration,
cystic fiber,
recurrent urinary tract infections,
yes,
recurrent UTI. Okay, continue.
Yes, madam. No history of constipation because of hypokalemia. There can be constipation, or it can be part of the.
No. Do you expect babies with salt wasting tubulopathies be constipated?
No, madam.
Yes, we expect them to be constipated because they will be chronically dehydrated. And then that will lead to chronic constipation. So that negative history, you will have to go back and ask, maybe the baby is constipated. Okay, next.
Yes, madam. And because of there is excessive urine loss, child can have salt craving, madam.
Yeah, these are
So
all
I asked,
the tubulopathies. Most of them are salt wasting tubulopathies, and they may have salt craving. And which one will not have salt craving, but lot of urine will be lost? Which disorder will be polyuria is there, but no salt craving. They will rather go for even very cold water. They will turn around and drink their own urine. What is that disorder? 6-month-old baby will turn around and drink his own urine. What is that disorder? Diabetes insipidus. Okay, diabetes insipidus. So it will be very hypotonic urine. They will be craving for water, but no salt. Okay, continue.
Yes, madam. No history of any abnormal odor or smell, because since there was sibling death, I would like to consider inborn error of metabolism also should be kept in mind, and we should rule out. No history of any loss of obtained milestones, since we would like to rule out neurodegenerative disease also. No history of any visual disturbances. Because in mitochondrial disorders there can be both visual loss and both hearing and visual affected in Kearns-Sayre syndrome. So I thought of that.
What about Fanconi syndrome, cystinosis and all?
Yes, madam. They can also
they can
because
have
of the Japanese
photophobia, visual disturbances can be there. Okay, continue.
Yes, madam. And child was evaluated at SATH hospital, and during those time also child had some abnormalities in blood, and child was started on oral medication, and it was told to kept under follow-up, and child was under regular follow-up. But 3 years child had over height gain as per mother, during which for which child was been admitted and been evaluated. And mother told that there is some decreased level of growth hormones, and child was started on growth hormone injections subcutaneously daily. And during that time also, hearing assessment was done, and child was found to have bilateral hearing loss in both ears, and hearing aid was prescribed to the child. And after mother told that after starting medications, there is mild increase in weight, height, and there is slight reduction in polyuria and polydipsia. Symptoms was not completely resolved, but there was slight improvement in those symptoms. And till now, now child is 10 years of age, and till now child is under.
So go back on that. So you have found that this child, after starting the medications, not having good height gain, and is evaluated to have growth hormone deficiency and also hearing loss. Can you tell what are the common tubular disorders that may be associated with hearing loss?
Yes, madam. In Bartter syndrome, there are 5 types, out of which type 4 sensory neural hearing loss can happen. In type 3 also hearing loss can happen. And in RTA with Bartter also hearing loss can happen, madam. And and in case of other like Alport syndrome, there can be hearing loss.
But Alport syndrome presentation is
Kakut,
totally different, no?
Yes, madam.
Yeah, okay. Okay, continue.
Yes, madam. Now, child is 10 years of age, and child is now under regular follow-up on oral medication. And we can see the weight gain pattern, that is birth weight is 2.2 kg. At 6 months, it is 3 kg. And 1 year, it is 3.65 kg. And 4 years, it is 6.3 kg. 5 years, it is 9 kg. And 8 years, it is 13.5 kg. Now, child is 17.1 kg during last follow-up. Now milestones are under catch-up, attaining catch-up. Child is now able to walk, run, and able to tell 2 to 3 words in sentence. And now also child is passing urine 8 times per day while in home, and passes 2 to 3 episodes stools per day.
Okay. So right now, you have completed that, completed the history.
Yes, madam.
Yes.
Yes, madam.
Yeah. So now I will be asking the teachers in the forum to ask questions to Arun so that we can discuss more before we proceed further. All questions are welcome.
Arun, what are the causes of seizures in a child like this? Suspected CKD or suspected tuberculopathy?
Madam, seizures may be because of some, there can be electrolytes, because of hyponatremia, hypocalcemic seizures can happen. Because of mainly there can be electrolyte disturbance for, because of the electrolyte disturbance seizures can happen. Madam. Hypocalcemic seizures and hyponatremic, the hypomagnesemia also can cause seizures.
Okay. Is there any possibility of hypertension causing seizures in a child with polyuria?
Yes, madam. Yes, madam. In case of Liddle syndrome, there can be hypertension causing seizure, madam.
Venovascular hypertension can occur. Okay. That
Yes,
can
ma'am.
have
Yes,
polyuria.
Yes, ma'am.
Any more questions?
Arun,
Sir.
one suggestion for all the postgraduates is to listen to the previous discussions also. Maybe first time you're coming and presenting because we have discussed previous discussions also. One point is never mix all the investigations part in the presentation. So better make use of the history given by the mother for the analysis of the complaints. Don't mix up too much of investigations and proceed. So from the mother's own words, make use of this thing. So hard findings in this case is polyuria and the time of onset and the survival. The female baby had antenatal period itself evidence of polyhydramnios, not due to an upper obsession, must be having one reason, likely polyuria, may be due to multiple reasons, starting from antenatal period onwards. And with management, whatever, he's surviving up to 10 years. So those 2 points need for the evaluation. So hard finding definitely is polyuria. And in this case, the first 3 months, whether there was polyuria, that you didn't mention because antenatal period, it was started. And naturally, the polyuria must be there from the newborn period itself. You told 45 days onwards, they noticed the polyuria. Actually, that part also, the period also, polyuria is there. So that is a thread you will be catching hold of and going forward. All the reasons for polyuria need to be considered starting from the basic, the central or renal situation. So other possibilities, other points, excluding or suggesting the neurological part that should have been mentioned because any hypothalamic or pituitary problems leading on to the diabetes insipid state also. Then if it is not, it is a tubular or tubulointerstitial situation. There again, just Madam was pointing out, when there are problems from seizure, neurological problems and visual thing, few of the conditions producing tubular damage later and other things also. Cystinosis is one important entity. And other situation you missed, you didn't mention was the liver problem because the tubular injury and the liver problems, there can be multiple reasons. The autosomal recessive polycystic kidney situation, say the other conditions like tyrosinemia, other conditions, there can be liver plus tubular injury. There are tubular injuries like Lowy syndrome, cystinosis, Wilson disease, but Wilson is not considered. But there can be a combination of liver also. Two systems need to be additional point are needed. And whether there was acidosis in between, the breathing you need to have mentioned about any problem with the breathing was noticed. And at present, there is no explanation for the ventilation at 6 months. So what was the problem? That's not clear. You said it's not a floppy hypercapnia, unlikely. Or is it, as Dr. Christy pointed out, always consider hypertension. Neurological problem can be due to multiple things. There is a seizure. So it must be electrolyte imbalance, can be hypertension, can be another problem, hypothalamic problems. So all those things need to be considered. At the end, definitely it's a problem of tubular, less likely a tubular interstitial also. Acid-base disturbance part clinically, the breathing was not disturbed. So starting from early period and with the management, she is surviving up to 10 years.
10 years.
So there is an inherited tubular disorder. So if it was a later onset, you need to consider many other conditions, acquired form also, tubular injury, heavy metal poisoning, other things. That's all out. And one point is cystinosis and other metabolic situations damaging the tubula is unlikely just because the onset is so early and antenatal. So all the small molecular or these things sort of situations will not start from newborn period, a little later. Antenatal is very unlikely. So that point is also very important. Some malformations or a syndromic situation is more likely because it has started at an antenatal period. Dr. Susan, that's all.
Yeah, okay. Anything, Dr. Mohandas?
No, I will tell at the end.
Shall we move ahead? Srinivasan sir, Hariprasad sir, Priya. Okay.
Okay,
so,
madam, we can continue.
Yeah, okay. Okay, Arun, this point of ventilation, mechanical ventilation requirement without any fever, cough, what could be the possibility? What are the possibilities that we should be considering again? Can it be a muscle dysfunction that must have occurred at that point of time? Severe dehydration? So
Yes,
all
yes,
those
madam.
things we have to consider. Okay, so
Yes.
let us proceed.
Yes, madam. And coming to the developmental milestones and gross motor, child attained neck holding at just 9 months only, sitting with support at 1 year, sitting without support at 1 year, 2 months, and stands without support at 2 years, 6 months, and walk alone at 3 years, and walk upstairs and downstairs by 4 years. And child is now able to walk and run, and now attained fine motor, bidextrous reach by 1 year, unidextrous reach by 1 year, 2 months, mature grasp was at around just 1 year, 6 months, and child able to scribble at 3 years, and copy circle by 4 years, copy triangle at 5 years. And coming to the language, child able to started cooing at 6 months, and monosyllable only just at 2 years, and bisyllable by 6 years, and able to tell 2 to 3 word sentence at 9 years. And social smile attained at 1 year, recognized mother by 1 year, waves Baba at 2 years, and able to tell his name at 4 years, asked to go to toilet at 5 years. So initially there was delayed at milestones, now attained catch up. And next is immunization.
So let us go back. So what is the developmental age of this child?
Now it is more than 70%.
And you are telling that the language is quite delayed. What could be the reason?
Madam, maybe because of this hearing language, there was for language there should be both visual and hearing also should. Because of the hearing problem, I assume that language may be delayed.
So that could be the reason. Okay. And fine motor, language is delayed. Fine motor and gross motor, what is your assessment? Fine motor, is it better than the gross motor?
It's madam. Fine motor also affected, but it is slightly better, madam. Maybe because till 2 years child was on recurrent hospitalization, and probably.
Okay, continue.
Arun, in this case of development assessment also, you need to give importance to the basic condition because there can be different patterns in this case. You said hearing is affected. So one question is, when was the hearing problem started? The hearing problem started later. Also is possible in few of the syndromic situations, onset later. So from that can be assessed by the language. So in a normally intelligent child, hearing normal, initial part of the language will be normal. And acquired language, once it acquired, the problems will not be much. The hearing problem will not be affecting the language much. Okay. The other thing, whether it is a gross motor only or the other milestones are also affected. Because if it is a tubulointerstitial only situation, there are a lot many. In that situation, you expect the gross motor only. That will not be affecting the social, intelligence, language, none of them. Here is a situation where gross motor, fine motor, social, all these things are also affected. So that all are important because multiple system involvement, the syndromic situation is more likely. So the developmental analysis is very, very important, and especially the language is more important. So, okay. And from with the fine motor, you said able to tell this thing, previous. Copy circle at a triangle at 5 years. Copy triangle at 5 years. That is a normal. Okay. So copy circle by 4 years, there is a delay. Scribble 3 years. So such a trick of that sort of a delay, copy of a triangle is at 5 years is unlikely. So these are all small things you can be caught. Okay. There is a fine motor delay in the other fields, but copy is triangle by 5 years. So that's unlikely because that's is it getting normalized? It is unlikely.
Yes, sir.
Okay. Proceed.
Oh, yes, sir.
Arun, at what age the hearing impairment was they picked up and hearing aid was given? By what age?
Madam, during while coming to at 2 years only, during at 2 years of visit, they told advised hearing, madam. After that, after second visit, after 2 years only, hearing aid was kept, madam.
Okay, continue.
And coming to the immunization history, child is immunized till age, no adverse events following immunization. BCG scar was
regarding this, Arun, whether the hearing aid worked.
Yes, sir. Worked, but recently now only child is not compliant to hearing aid, sir. It was worked.
Anyway, that's important because what type of hearing, sensorineural or the other one? Okay. So, and one more point, whenever you get a hearing problem in association with this thing, medications. Was there any other possibility of a medication for the UTI or something, aminoglycoside, something leading on to? It may be part of the syndromic itself, but the other reasons need to be considered in the type of the hearing also is important. Okay. Proceed.
Yes, sir. And coming to the immunization history, child is immunized till age, no adverse event following immunization. BCG scar is present. Child attend pulse polio program and received iron, vitamin A prophylaxis till 5 years of age, and optional vaccines pneumococcal, typhoid and varicella was taken. And coming to the dietary history, and according to 24-hour recall dietary method, child is expected latest 2000. According to ICMR guidelines, expected is 9,950 calories, and the child is getting 1,200 calories. There is a deficit of 750 gram, and protein should be 41 gram. Child is getting only 28 grams, and there is a deficit of 13 grams. And the child is now taking plain water most of the time, and mother does not remember whether exact amount, but usually mother says child is taking more than 2 liters and sometimes more than 1.5 liters. Exact quantity was not known.
Okay.
Shall I proceed, madam?
Yes.
And coming to the family history, and as I said, it is a second child. There is a history of neonatal death in sibling, And first child is all trimesters were uneventful, except during that time also mother had maternal polyhydramnios. First child is a preterm. It is a 1.2 kg. It is a female child, and they were admitted initially in a private hospital for lower abdominal pain, and it was a spontaneously vaginal delivered around 7 months of gestation. Child cried soon after birth, and there was history of some respiratory distress, and child was kept on oxygen therapy. And in this child also, during second week, mother noticed that there is increased frequency of urination, and there was some abnormalities in blood levels. And during those periods, child was started on some medication, and at around 36 days of life, child was expired. And exact reason was not known to mother, couldn't remember. We can see it is a second child of non-consanguineous marriage, and there was no history of any abortions, no history of any renal disease in the family members, no history of any hearing loss in the family members, no history of any other genetic disorders in the family members.
So this, the first baby also, she was having polyhydramnios. She
Yes,
noticed
madam.
increased volume of urine postnatally. So then
Yes,
it is surprising that this mother was not cautious with the evaluation of the second baby who was also having the same features. No, any explanation for that she was giving?
Not specifically, she didn't hold.
She was not sure about anything. Okay.
Yes, madam.
Okay, continue.
Arun, may I ask one thing? Why a triangle is drawn for the first
Why
baby?
a triangle?
Yes.
It was a female baby, no?
Yes.
And why you are drawing a triangle?
Sorry.
Huh? What would have been there?
It should be a circle.
Huh?
Circle, madam. Female.
Okay.
Yes.
Arun, when
Yes,
you try a family pedigree chart, it's very important because one generation, two female kids are affected with a similar disorder. Most likely that baby also so severely affected.
Yes,
And, one of the pointers in the clinical features of this child was the deafness. So in the family history, every possible spectrum of the clinical point you need to ask in the family members. Any of the family members having a hearing problem, any other family members having any bony problems or stature, like that. So that should be the method of a family pedigree chart, concession and the history. So not only renal disorders, other manifestations possible, all to be included in the pedigree chart concession. Deafness is definitely one point to be searched for in the both sides of the family. Okay.
Yes, sir.
Okay, continue.
Yes, madam. And coming to the socio-economic history, they live in a Pekka house, 3 rooms with 2 windows each. There is separate sanitary facilities and drinking water from municipality. Other education is studied up to high school. So skilled labor, and monthly income is 40,000. And according to modified Kupuswamy scale, they comes under upper middle class too. And there was no history of any exposure to pet animals, no history of any passive smoking, no history of any for cooking they are using gas stove. There was no any allergy to food, drug or dust, no history of any contact with TB patients. And treatment history, currently girl is taking some tablets, oral medication and syrup containing potassium, and child is taking daily growth hormone injection.
Okay.
Madam,
So before you
summary.
summarize in that pedigree chart, what is the, when will you use the triangle?
Madam, when sex is not unknown.
That is diameter.
Yes, madam. Madam, hello.
When the pregnancy is not reaching the term.
Yes,
okay, continue.
Arun,
sir.
is she having a nocturnal requirement for urination?
Can you
no, sir. No, sir.
So most likely because of polyuria, if it is persisting,
Oops.
there must be a frequency at night also. So a 10-year-old girl child having nocturnal urination requirement or when you ask about the social, family and all, you need to check whether the toilet facility, the rooms, it's a girl child, 10 years. Okay.
Sir,
All the aspects of the life also for such a child need to be considered. Okay. Polyuria at night, most likely it must be there. The having attached bathroom?
yes, sir.
Okay.
Sir. And coming to the summary, it is a 10-year-old girl child. It is a second child of non-consanguineous marriage with a global developmental delay, now attained catch-up immunized till age, with history of sibling death, with similar history like polyuria, and with antenatal maternal polyhydramnios in both pregnancies, and now presented with failure to thrive, polyuria, polydipsia, and initially needed hospitalization for vomiting and loose stools requiring IV fluids, and oral medication with decreased height on growth hormone injections daily, with history of hearing loss of both ears, and now on hearing aid, now came under follow-up. So I would like to consider some differential diagnosis. First, I would like to consider inherited tubulopathies because there is history of and among inherited tubulopathies, we would like to consider Bartter first because there is a history of maternal polyhydramnios. In Bartter antenatal type, there can be maternal polyhydramnios, and there was history of some electrolyte abnormalities was there. So and there is history of sibling death also there, and there is polyuria, polydipsia, and failure to thrive. All these can occur in Bartter syndrome, and there is history of hearing loss also. And in Bartter syndrome, 3 and 4 types hearing loss can happen. And I would like to consider renal tubular acidosis also. In renal tubular acidosis, there can be failure to thrive, polyuria can happen. And I would like to consider other conditions like cystic fibrosis. Cystic fibrosis can present as a failure to thrive. And point against this, there is no history of any recurrent infection and no history of any chronic diarrhea. And I would like to consider chronic kidney disease also. There was history of decreased height gain, and points against this, there was no any bony deformities. And I would like to consider diabetes insipidus also because there is history of polyuria and polydipsia. And I would like to keep in mind gentlemen also, but points against this, gentlemen usually comes in the late presentation or early adulthood. So I would like to consider these possibilities.
May I ask one question? Can you hear, Arun?
Yes, sir.
How long he's on growth hormone?
From 3 years onwards, sir. From 3 years to now 10 years. Since 3 years.
I think the benefit is there with the growth hormone?
Yes, sir. Yes, sir. There is gradual increase in height is there, sir.
That's a vague answer because you need the increment of height in the initial years and later years. Is it responding to growth hormone? What is the, how much is the she's acquiring?
Velocity.
But not the velocity, annually, acquiring. Is it responding? That is one. And very important, what are the drugs she's getting? What are the types of drugs?
Yes, sir.
Because in the clinical situation, you are going into different possibilities, and basically it's a tubular disorder. Okay.
Yes, sir.
What drug she's on is also important. Susan, go ahead.
It's okay. It's okay, sir. Okay. So, Arun, what are the different causes of CKDs associated with hearing impairment? Apart from the, Bartter syndrome can be tubulopathies, you are right, Bartter, renal tubular acidosis. Can you think of other diseases? Just forget about the electrolyte disturbance and the polyuria and things like that.
Madam,
ear and eye, ear and kidneys.
Alport
Yes, Alport syndrome.
What
Okay.
Alport syndrome. In
Yeah.
congenital anomalies of kidney and urine tract, there can be anomalous here.
Yeah, that is called Bohr syndrome. What is Bohr syndrome? Bronchio-oto-renal syndrome. You have to look at the neck of the child, whether there are some sinus or fistula, bronchial fistula or bronchial sinus that is there, may be associated with any ear anomaly, like abnormal ears or hearing impairment. Then,
And it's because of the chronic drug usage, there can be diuretic induced.
what about Lowy? Sir was talking about Lowy syndrome.
There can be both ear and eye abnormalities can.
Yeah, okay. So there are different diseases which can be associated with ear abnormality and kidney abnormality. Okay. So all those things, so you should be putting it down in the differential diagnosis, even though you know that some of these diseases may be not very common, or the features, the dysmorphism that may be there will point to the possibility of Lowy is another thing that you have to, another disease, because there is history of seizure, there is history of hearing impairment, there is a child who is having failure to thrive, electrolyte disturbance. So Lowy is also another possibility in this child. Okay, because you know the diagnosis, but when you are analyzing, you should be putting across all the possibilities as if you don't know the final thing. You know the final diagnosis in this child. That is why you are a little skewed in your presentation. It should not be like that. Okay.
Okay, ma'am.
Continue.
Coming to the examination, general command, child is alert, interested in, child is alert. There was no pallor, icterus, cyanosis, clubbing, there was no lymphadenopathy. And coming to the head to foot examination, shape of the head appears normal, hair appears normal, eyes appears normal. And there was, we can appreciate there is some dysmorphism, there is prominent ears and large prominent nose. And there is some pointed chin was there, and mouth and tonsils were normal, neck was normal, chest wall appears normal. There was no any widening of wrist or bony deformities, and abdomen appears normal, and spine and external genitalia was normal.
What about the malnutrition? What about the fat distribution in this child?
Madam, symmetrically there is child is thin built, and there is
so that is also important, no? Is there any muscle wasting that is there? Even the buccal pad of fat when you're looking at the side. What about the triceps fold thickness? What about the interscapular area? What about the fat folds that are there? That is the skin fold thickness. Though all those malnutrition features are very, very, for a child of 10 years with malnutrition, the usual pattern of assessment may not hold. So you have to show all that also. Okay.
Okay. And coming to the vitals were stable, 94 beats per minute, regular, normal volume, normal character, no radiofemoral delay, peripheral pulses felt, and respiratory rate was 24 beats per minute, abdominal thoracic, BP 98, 60 millimeters of mercury measured in right upper limb at sitting position, saturation was 98% on rumor, and temperatures was normal. And coming to the anthropometry, weight for age is observed is 17.1 and expected is 32. It is less than third centile. Child is severely underweight, and height for age is 122 centimeter. Expected is 136. It is less than third centile. There is stunting, and BMI expected is 16.8 and observed is 7.5. It is also less than third centile. There is thinness and head circumference normal. This was the growth chart during follow-up. All were less than third centile.
So you have to show in the growth chart, like Purushottam sir was telling, the point where you started the growth hormone and the point before the growth hormone. That part is very, very important. Okay.
Okay. And coming to the system examination, abdominal inspection.
In the examination, when you're talking about any standard child,
yes, sir.
The proportion also is important.
Okay.
Proportion and the mid-parental height should be there in the chart always. In the chart, mid-parallel height is the needed and the proportion you need to mention. Okay. In the respiration examination, you need to tell about the depth of the breathing also.
Yes.
Tell about the rate. Okay. In the eyes, again, the cataract is one thing. Eye is normal. Okay. Both are important. But the cornea is important. Lens is important. Fundus is important. Okay. Eyes are normally mentioned, but still keep that positive. Okay. Go ahead.
Yes. And coming to the system examination, shape of the abdomen inspection, shape of the abdomen is scaphoid. All quadrants moves equally with respiration. Umbilicus is normal in position. No stars or dilated veins. No visible pulsations or peristalsis. Inhale orifices are normal. Exhale genitalia is normal. And palpation of abdomen is soft, non-tender. Liver is palpable 1 centimeter under right costal margin in midclavicular line. Spleen was not palpable, and liver span is 7 centimeter. There was no apotomacally, and bowel sounds heard, no venous or pruvi. And coming to the next examination of central nervous system, and child is well groomed with clean dressing. Child is alert, oriented to time, place, and person. And coming to the cranial nerves, and all were normal except because of this hearing loss, child that is on hearing aid. Venous test was positive, that is air conduction is better than bone conduction. Weber's test is equally heard, and the bulk of the muscle equal on both sides. Tone appears normal. Power in both upper limbs and lower limbs, it is grade 5/5, and reflexes were superficial and deep reflexes were normal. And a sensation of touch, coming to the sensory system, sensation of touch is perceived. There was no nystagmus or no either cerebellar signs, and skull and spine appears normal. And coming to the other system, that is cardiovascular system, apex is located at 50 intercostal space, just medial to midclavicular line. First and second heart sound heard, no S3 or S4 or no murmurs. And coming to the respiratory system, there was no sinus tenderness or sinusitis, and there was normal vesicular breath sounds heard. And bilateral R entry was equal, no additional sounds like repetitions or wheeze is present. Sorry. Hello. Arun?
Proceed, Arun.
Madam, coming to the summary, it is a 10-year-old girl child. It is a second child of non-consanguineous marriage with global developmental delay, who has now attained catch-up and immunized till age, with history of neonatal death in sibling, with history of polyuria, and with both pregnancy there is antenatal maternal polyhydramnios, now presented with failure to thrive, polyuria, polydipsia, and there was history of some electrolyte abnormalities, and there is short stature on daily growth hormone injections, with history of hearing loss in both ears. And on examination, child is having some facial dysmorphism, and with severely underweight, and stunting is there, severe thinness is there, no evidence of any recurrence is present.
So are there any other vitamin deficiencies that are there? This child is severely...
No, madam, there was no white hot spot.
Okay. So child was not anemic also?
Yes, madam. No, she was anemic.
Okay. So again, you would like to consider the differential diagnosis. You would like to consider what all possibilities now?
Yes, madam. Since there is, again, I would like to consider inherited tubulopathy suspect Bartter syndrome among those first, because there is a history of maternal polyhydramnios, and there is history of sibling death, and there is positive findings like polyuria, polydipsia, failure to thrive is there, and there is history of some electrolyte abnormalities also there, and sensory neural hearing loss, and renal tubular acidosis also, as I said, there is history of failure to thrive, and polyuria was there. And even though we should rule out, and we would like to consider same others like cystic fibrosis, cystic fibrosis, and I would like to evaluate for chronic kidney disease also. And I would like to consider diabetes insipidus since there was
Stop
history
there.
of poly.
No, gentlemen, stop there. And
Yes,
tell
madam.
me what are the points in favor and points against each of these diseases.
Yes, madam. First is the Bartter syndrome. Bartter syndrome points favoring are there will be history of maternal polyhydramnios. In first sibling, there was a preterm vaginal delivery. Usually, there will be preterm vaginal delivery, and because of the history of polyuria, polydipsia, and Bartter syndrome can present as failure to thrive, and child is having vomiting, low stools skew was also there, madam. For renal tubular acidosis, points favoring is failure to thrive, polyuria, and against is there is no rickets, madam. And cystic fibrosis, against point is no history of any recurrent respiratory tract infection or recurrent respiratory tract infection, madam.
Recurrent respiratory tract infection. Then what are the other features of cystic fibrosis?
Madam, meconium ileus, madam. Child had passed within 24 hours of past meconium.
Okay.
There can be no chronic diarrhea, pancreatic insufficiency can be there in cystic fibrosis, madam. And there was no clumping in cystic fibrosis. In cystic fibrosis, there can be anemia, no anemia. And points against CKD is there was no anemia. Short stature is there, but there is no bony deformities was not there. And points against
chronic CKD, what will you get? Polyhydramnios or oligohydramnios? What will be there for CKD?
Initially there will be
Oligamnios or polyhydramnios? Is polyhydramnios a point against CKD?
Oligo, madam. Oligo.
What are the possibilities of fetal? What are the causes for a neonate presenting with kidney failure, chronic kidney failure? What are the different causes?
Madam, in case of like bilateral renal genesis, there can be oligohydramnios.
Potter sequence. So what are the other associations for Potter sequence?
Madam, usually there will be pulmonary hypoplasia will be there, madam. Bilateral renal agenesis with lung hypoplasia will be there. So because of the lung hypoplasia, usually death will happen. There is non-visualization of the bladder and non-visualization of bladder and bilateral agenesis with lung hypoplasia and facial features, madam. Facial features can be
only that much. So you are telling that the baby is born as a stillbirth. What will be the manifestation immediately after birth? Baby will be in the NICU.
Respiratory distress.
Respiratory distress. So why there is
ventilatory?
Yeah,
madam, because of the lung hypoplasia, child is not able to expand.
So lung hypoplasia, somebody started resuscitating, and then what will happen? Baby can develop.
They will get pneumothorax.
Yeah, what will be the limbs like?
Madam, there will be limb anomaly, shortening.
Shortening or contractures? So in utero, actually, the baby is drinking urine, developing his lungs and gut, and swimming in urine, that is amniotic fluid, and developing his joints.
Yes, ma'am.
Okay. And so there is a question, what was the SMR staging in this baby? And any chance of pan-hypopituitarism?
If there is pan-hypopituitarism, there should be all other hormones should be affected. There was no issue.
So pan-hypopituitarism, so that there comes the importance of showing the short stature as whether it is proportionate or disproportionate short stature, which you haven't done.
Yes.
Okay.
Yes.
What are the points against panhypopituitarism in this baby?
Madam, there was no cherubic fascias, or there is no midline deformities. Central in single incisors will be there, and there was no history of hypoglycemia.
What is septo-optic dysplasia?
Madam, optical disturbance, visual disturbance can happen.
So again, underscoring the examination of eyes, no?
Yes.
Okay, so each point is important in clinical analysis. Even if you think that. So what was the SMR staging of this baby?
SMR, 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 the external genital.
Urine assess.
Yes,
do you think it is important?
It is important.
Okay. So you want to, anybody want to discuss any more about the differential diagnosis?
I think the cystic fibrosis is chronic kidney disease, whether that should have been mentioned here at all.
Cystic fibrosis is actually a very, very important differential diagnosis for the first diagnosis of the means Bartter syndrome. It is called pseudo Bartter syndrome. So it is important.
Yes.
Because it can mimic, cystic fibrosis can mimic all the electrolyte imbalances of Bartter syndrome.
Will it have polyuria, Dr. Hussain?
Yeah, they can have polyuria also because of the chronic hypokalemia that is there. There will be affection of the tubular functions, and there can be chronic interstitial fibrosis that is coming up. So it is even termed as pseudo-Bartter. So that cystic fibrosis is an important. Sometimes we have seen 1 or 2 cases where we thought the diagnosis was Bartter, finally turned out to be cystic fibrosis. But the major point of differentiation is actually the assessment of urine chloride, which will be actually low in cystic fibrosis and it will be very high in Bartter syndrome. So you have to assess so we will be coming to that later. And even CKD is important because renal hypoplasia, dysplasia, and chronic kidney disease with means progressing to 3 and 4 can present like polyuria, and cystic kidneys, polycystic kidney diseases, PCKD spectrum can present like this. But those conditions will not be associated with polyhydramnios. Those conditions will be associated with oligohydramnios rather than polyhydramnios. So maternal polyhydramnios is a real clue towards the diagnosis of Bartter.
No, that is the thing. I think you should have stressed more about the prenatal onset of the disease and also possible autosomal recessive mode of inheritance.
Exactly, yeah. Exactly, yeah.
And
that also should have been highlighted.
apart from some congenital anomalies of the kidney and urinary tract, I don't think any other condition present with prenatal onset and polyhydramnios.
Yeah, very, very good point.
And regarding panhypopituitarism, they usually look, they have a adipose look.
Yeah.
They don't look this much wasted.
They all look very nice, no? Small and nice looking. Okay.
And another thing is regarding this muscle bulk. You have mentioned that it is equal on both sides. That is not sufficient. You can have abnormality even if it is equal. There can be significant wasting or hypertrophy. So along with that, you should have mentioned there is significant wasting also.
Yes.
And in the profile view of the child, the neck looks very much thin and cylindrical, probably because of muscle wasting.
Yes, sir. Okay.
Shall we proceed? Srinivasan, sir.
You have discussed in detail. So I have nothing else to this thing. But of course, pseudo water is well known, but will it cause polyhydramnios? I was wondering.
Yeah, polyhydramnios
Yeah.
is a point against, sir, all those.
Yeah. That is the only point I wanted to
Yeah.
verify. Yeah.
Okay, Arun, continue.
Yes, madam. I would I will I'm these are some investigation and hemoglobin is 30 CBC hemoglobin is 13.4 gram per deciliter and total count is normal 12,800, polymer 30, lymphocyte 40, platelet is normal, CRP non-reactive. You can see there is chronic compensated metabolic alkalosis and pH is 7.51 and bicarbonate is 30, PCO2 is 44, chloride is 82. And these were some of the investigation which I took from those follow-up visit. We can see there is hyponatremia, hypokalemia, hypochloremia, and hypomagnesium cause.
Go back to previous slide.
Yes.
In the TCDC also, where 30, 40, what are the other cells?
Other cells, zeros, eosinophils.
Okay,
Yeah.
that,
Yes.
when I'm talking, you need to complete that also. Okay.
Yes, sir. Yes.
About the ABG, it's a alkalosis, metabolic alkalosis.
Alkalosis.
With?
What is chloride?
Compensated anion gap is normal. Hypochloremia.
So the metabolic alkalosis is there, and what is the expected PCO2?
That's all. You need to complete all those.
Yeah.
Sir, madam, expected PCO2 is that is by formula 0.7 into 30 plus.
0.7 into 6.
30 plus
4.6 increase is expected. So it is
Yes,
actually PCO2 is expected. PCO2 is 44 to
44.
86. Yeah, it's okay. And hypochloremia is severe, 82. When was this blood gas taken? This is at what age?
Madam, during that 2 years while
yeah, when the child initially presented to us. At that point,
madam.
you can see that there is severe metabolic alkalosis with a pH of 7.51. What was the sodium and potassium at that point?
Yes, madam. At that point, previously also 127 and potassium is 2.9, chloride is 68 low, and bicarbonate is 33. Magnesium also was low, 1.52.
So better in a case like this, always everything needed for the ABG analysis on one slide.
Yeah, exactly.
Okay, sir.
pH, carbon dioxide, HCO3, the chloride, then sodium, the potassium, and then calculate all these things, the expected compensation, the anion
Actually,
gap.
this slide should come before the other slide. Yeah,
Yes,
because these are the things with which you are calculating that.
Okay.
And coming to the urinary chloride levels, which is elevated, that is 170 millicalories per liter, and ultrasound was done during follow-up visit that after 3, which is normal size.
So before you proceed further, can you analyze all the investigation results that are there and give us a complete diagnosis regarding the electrolyte disturbances and the acid base?
Yes, madam. Madam, there is hypochloremic metabolic alkalosis and with hypokalemia and hyponatremia.
And there is?
Hypomagnesemia also.
And? Is it a chloride? This is
elevated chloride.
Renal or extra-renal? Yeah, there is a urinary chloride of 170 with a serum chloride of 62, 68. So it is actually, there is a wasting of chloride through from the kidney.
with me.
Okay, so the kidney is the culprit here. So it is a
Yes.
hypochloremic,
Hypochloremic, metabolic,
hypokalemic, hyponatremic, metabolic
alkalosis.
with chloride wasting in urine. Okay,
Yes,
so
madam.
that clinches your diagnosis of the renal tubulopathy,
Barter.
which is associated with metabolic alkalosis, and that is
Alkalosis.
Bartter syndrome.
Bartter
Okay.
syndrome.
So you should be writing that here.
Yes, madam.
You did estimate the urinary chloride only. What about other things?
Other things, serum, other was there, sir. Mention.
What about what is your expectation of the urinary sodium?
Sodium. That's very, very important. Because don't be biased with the, Arun, that's a problem with you. Biased with the diagnosis and then moving forward. So what do you expect about the sodium in a case of polyuria child? That is one very, very important. We are considering diabetes insipidus. You are considering the renal tubular problems responsible for polyuria. When a polyuria occurs, what do you expect with sodium?
Should decrease.
Decrease. Is it so? When there is a polyuria, what will be diabetes insipidus? What will be
Hypernatremia.
But what is happening here?
Here hyponatremia.
So what exactly? So then that's
it is against.
It's also significantly lost in the urine.
Yes,
Otherwise, it cannot be 127. In the context
yes,
of hyponatremia,
yes,
means tubular loss is there. So
yes,
before judging on to one diagnosis, you need all those things. Urinary,
sodium.
Having a tubular problem, we are considering Fanconi's and all. So urinary, everything can be lost. When you are considering a tubular problem, urine analysis is so important, starting from the volume, starting to the pH, specific gravity, and every component in the urine is important.
Yes.
Okay, not only chloride only. That's because our biased situation now. Okay.
Okay. And pure tone audiometry showing bilateral moderate to severe sensory neural hearing loss. And this was the latest investigation during last week, and the urea was 32, creatinine is 0.6, cholesterol is 240, calcium is 10.4, phosphorus is 4.6, and OT is 30, PT is 38, and the serum total protein is 7.8, albumin 4.6. Now sodium is 136, potassium is 4.3, magnesium is 2.39, urine protein was done, which is normal. And
the previous slide. Don't go forward. I'm going to jump in.
Yes, sir.
Next slide. So what is odd here? There is a 240 cholesterol. Is it possible? Is it likely, or do you want to repeat?
I need to
Malnourished child, failure to thrive child, no other explanation for this thing? You are getting a cholesterol 240. Do you expect that?
No, sir.
So whatever odd thing, you need to have an explanation before going forward. Okay. Susan, how can this be explained, Susan?
Yeah, was it
postprandial,
there is
fasting postprandial.
Postprandial cholesterol. That is one possibility. We have to do a fasting like profile, repeat it and see. We cannot explain such malnourished child unless there is a familial dyslipidemia is there. Okay, we will repeat it and see fasting lipid profile. It is an odd point.
Okay.
Right. Can we proceed, madam? Next.
So Arun, this investigations now are showing a sodium of 136, potassium of 4.3, calcium 10.4. What urine you have written normal? What evaluation should be done in all cases of Bartter syndrome during their follow-up? What investigation in the urine should be done?
Madam, there will be hypercalciuria, madam.
Yeah.
Urine calcium creatinine ratio, and they can have chances of nephrocalcinosis, madam. They should have.
Yeah, even though you know that all the Bartter syndrome, all the types may not be associated with all types, may not be associated with hypercalciuria and nephrocalcinosis, but we should be looking for that so that we can manage and prevent the nephrocalcinosis from occurring. Okay, so what is the GFR of this baby now?
Madam, 83, madam. 83.
Okay. Do you think that is normal for a 10-year-old?
Oh, madam, stage 1.
Stage 1 CKD.
Madam, can I ask one question?
Yes, sir.
Yeah, because I don't know, I am ignorant. What is OT bar PT? I am not able to understand that abbreviation.
What's it?
SGOT
Huh?
and SGPT. SGOT.
Okay. I was wondering whether it is something.
Yeah.
Okay. Okay. Sorry for my
So
ignorance.
no problem, sir.
Yeah,
Nowadays,
yeah.
a lot of short forms have come up. The new generation. Okay.
Sorry.
Yeah.
I should have.
Arun, what is the stage of CKD when the GFR is 80?
Madam, stage 2, madam.
Stage 2. Why do you think this child who is reasonably managed, like sodium is 136, potassium is 4.3, and bicarbs, you haven't put the bicarb. So why this child is having a CKD stage 2? What is the reason? What could be the reason?
Madam, because of since child is taking medications from 3 years to 10 years, because of the chronic drug usage, that can be drug induced there can be because of the
Don't blame the doctor first. Blame the condition first.
Madam, because of the chronic condition.
That's a good statement.
Because of the
okay.
First, madam, because of chronic
chronic dehydration, chronic dehydration, hypovolemia, hypokalemic nephropathy,
Yes,
then hypercalciuria, nephrocalcinosis. This baby is not having nephrocalcinosis, but yeah, hypercalciuria you haven't looked at. So if that is there, that also can produce a chronic tubulointerstitial damage. So all these causes will cause progression of CKD in untreated barter. And treated barter, all these factors, if it is not optimally controlled, can affect, plus the drugs that you are using. Okay. So always blame the drug last. That is a secret that you have to follow. Okay. Okay. Which drug can produce chronic damage?
Indomethacin.
Yeah, the NSAID that we will be using. Okay, continue.
Shall I proceed, madam? We have done clinical exam, which showing it is autosomal recessive Bartter syndrome type 3. It is we can see gene involved is CLCNKB, likely pathogenic variant is possible.
Okay, Christy, can you explain this genetic report?
Madam.
Christy?
Yes, ma'am.
Yeah.
There is a homozygous pathogenic deletion in exon 2 to 10 of CLC and KBG. It's a large deletion from exon 2 to 20. You can see it's in the location exon 2 to 20. And in the variant part, they have written exonic deletion. In the zygosity part, they have written homozygous. Since it's implicated in the disease, under the OMIM, it's written Bartter syndrome type 3. And usually it is inherited as autosomal recessive. It's written
and which
under
is the chromosome?
CLC and KB. I don't know, ma'am.
Yeah, it is chromosome 1. So this is chromosome 1. Okay. Okay.
And last time, its classification is the ACMG classification. Likely pathogenic.
Okay.
Either likely pathogenic or pathogenic, you can usually consider it as significant in case of a homozygous state in an autosomal recessive.
So this is definitely a significant and proven Bartter syndrome 3, type 3. Okay. Arun, please proceed. How did we manage this child?
Yes, madam. Child was started on first by giving more in food. There is increased salt, and the child was started on indomethacin and aldactone and the syrup containing potassium, that is potassium chloride. And there was during follow-up there was magnesium, and child was given magnesium oxide, and by giving ORS also. And currently now child is last follow-up child is on 3 mg per kg per day indomethacin, that is 25 milligram BD, and tablet aldactone, that is now is child is 1.4 milligram per kg per day, and pot 2.5 ml QID, that is now child is on 0.8 milligrams per kg per day, and on magnesium, that is 23 mg per kg per dose, and child is on vitamin supplementation, and the child is during any vomiting or diarrhea, we are advising to take more ORS and to take potassium rich foods and
Okay. Okay,
yes,
so growth hormone was started at 3 years. Do you have
uh,
the growth hormone assessment that was done at 3 years in the presentation? Do you have those?
Madam, that value mother during last time she didn't bring that book was not there, madam.
So this baby, actually, there is a question in the chat box. Any explanation for severe growth failure despite a relatively normal renal function and electrolytes and growth hormone replacement from 3 years of age? A very good question, because some of the Bartter syndromes, it is always reported that if after you correct the electrolyte imbalance and you correct the dehydration, you expect the Bartter syndrome children to grow well. If they are not growing, you have to assess the growth hormone. Assessment is to be done. You have to, this child had a clonidine stimulation test, and we found that this baby is having associated growth hormone deficiency also, which can be an association in some of the Bartter syndromes. And then after starting the growth hormone, the child started growing. Otherwise, the growth was very, very slow, and it was almost not there. So after we started, the baby started growing. So this is not the first case that we are presenting. There are many case reports that are there. In the literature, there are reports that growth hormone deficiency can be there in Bartter syndrome. And the guideline is that once you correct the dehydration and electrolyte imbalance, if growth is not happening, you have to assess for growth hormone deficiency. Okay.
This neonatal Bartter also, they grow normally?
Neonatal Bartter also, after the neonatal Bartter, this antenatal Bartter syndrome is usually not a picture in classic Bartter syndrome. The other types can have antenatal Bartter syndrome, very difficult. Almost 20 ml per kg per hour will be the urine output in some of them. You will be putting a Riles tube, you will be putting lines all over, trying to replace the fluid. Most often it is very, very difficult, and some of them will be having an AKI also, which actually prevent you from starting indomethacin. And so if you get them out of this dehydration, electrolyte imbalance problem, usually in the infancy, we have not seen any baby not growing well. But as such, of all the tubulopathies you consider, Bartter is not a very good diagnosis to have. DRTA, they respond very well to the treatment, but Bartter syndrome, the overall growth profile is always, they remain below the 3rd centile in the growth. Even with all this medications and all the growth hormone supplements and everything, their growth is not good. I have not seen any neonate who is not thriving well, and we had to use growth hormone. No experience, not seen.
In fact, actually, is there any justification to continue growth hormone in this child is one question, because one thing, the indication, does that include this sort of a condition for starting growth hormone is one. And second thing is not getting response to growth hormone over these years expected, then another from 10 years on to 16 years, how much expenditure is involved for the government or for
but the family is paying, sir. And also they have been quite convinced that the growth of the child is better after starting growth hormone. Prior and after, there was great difference that the mother has noticed, and they want to continue. They can afford, they are taking.
What about
Is that also genetic, madam? Growth
That
hormone
is-
deficiency? Any gene was localized?
No, sir. It was not there. You can go back, all of you can go back and search the literature for growth hormone deficiency in Bartter syndrome. It is a known fact. Not all cases, but some cases.
And probably the improvement in development, can it be related to growth hormone because some muscle strength improvement or in such effects?
Maybe, Mohandas, actually we are having another Gittelman syndrome baby also having, who was diagnosed to have growth hormone deficiency from AIMS, Delhi, along with Gittelman. And he was actually belonging to a man who was working with the army. So they were getting it from the army, and they were also giving. So we are having actually these 2 children who are having on growth hormone with these tubulopathies. So Gittelman, actually, I have not seen the literature also, but that child was started from there, and after assessment, after the clonidine stimulation test and found that the growth hormone is very low. This child we have done and we have started and we have found the difference.
What's publishing, madam?
Thank you, sir.
What about the
Screen sharing can be stopped so that we can see each other.
Yeah, the screen sharing in this.
Madam,
Actually, Arun, you have
Madam,
done a wonderful
one doubt,
presentation.
madam.
Yeah, you have done a wonderful presentation. Almost all the questions
Thank you.
you were answering well. Congratulations. You are having a
Thank you.
doubt, you can ask.
Madam, this now for in clinical exam we got type 3, madam, classical.
Yeah.
But child was presented antenatally still.
Yeah, few cases of Bartter syndrome type 3 can present with polyhydramnios, but the other types will be more common to have polyhydramnios and the presenting in the neonatal period itself. Classic Bartter syndrome is actually a milder variety compared to the other types, and they usually present in early childhood or late infancy.
Yes,
I don't stop the presentation.
yes, yes,
Stop sharing.
yes, sir. Yes. Yes. Yes, sir, stop.
What is the born age now, Arun?
Born age, last month, 8.
8 years, huh?
Yes, sir.
So whenever you're they're telling about the dosage, in the this thing, it is per dose.
Yes, sir.
Okay, it's not per dose. If it is per dose, how many times?
Yes, sir. Yes, sir.
3 milligram per kg per dose. It's not enough. How many times?
Yes, sir.
Per day in divided doses. Okay, per day, how many divided doses? Per dose, how many times in 24 hours? And the B complex, is it simply or is it indicated? In the list of treatment, acetazolamide, potassium supplementation is there. All apart from this thing, B complex also.
Yes, sir.
ആവശ്യമുള്ളതാണോ ഇല്ലാത്തതാണോ എന്നുള്ളത് വെറുതെ ടോണിക്കേറ്റ് എഴുതിയാണോ?
Yes, sir. It is
Okay. ദാസേ?
Sir.
ഇനി എന്തെങ്കിലും വേണ്ട?
സമയം 9:15 ആയില്ലേ?
Comments? Anybody? Priya?
Sir, it was a very wonderful presentation. Arun did his job very well, and Susan Madam and all the teachers gave very nice inputs. And I think a dietary modification could salt. So in dietetic history, I think you can probably add that also, dietary modification.
Yes, ma'am.
Susan Madam, it was very nice.
Thank you, Priya. Thank you, Priya. And so I was just looking up at the Bartter syndrome and growth hormone deficiency. In the International Pediatric Nephrology Journal in 2012, there has been a report of 3 cases. They have a Bartter syndrome with growth hormone deficiency already published. So it is not an uncommon. And another, since all the seniors are...
Is it due to the same gene or there some other gene also is playing the part?
Bartter syndrome, it is not, it is actually, they have put only, I will go through the entire article I have to, sir. It is in 2012, I have to read. And another, because you were telling me, I think I have to start doing the MRI brain, because there is another case that was in a poster presentation due to a suprasellar arachnoid cyst, Bartter syndrome complicated by growth hormone deficiency. So actually we have to see more.
Yeah,
and
that's more likely. Yeah.
So whether there is some other association that is there, some other neurological problem that is there, that we will see.
Madam, I think growth hormone deficiency treatment ചെയ്തുകൊണ്ടിരിക്കുന്നതുകൊണ്ട് I think age, SMR, and a thyroid function test and serum cortisol.
Thyroid TFT normal ആണ്.
TFT normal.
Yeah.
Yes.
Okay.
How long this child is under your follow?
Actually, Mohandas, this child came to us at the age of 2. The baby was only around 3.54 kg at that time. They have already gone to multiple centers, including St. John's, Bangalore. They were roaming around. And so from the age of 2.5 years onwards, the child is following with us.
Madam.
Surviving to the stage with gaining milestones itself is very surprising. Congratulations.
Thank you. Thank you.
Any other inputs? I think it is already 9:50.
9:15, yeah.
Okay. So I thank Benno. Benno, are you there?
Yes, madam. Yes, madam. Okay, ma'am. So, on behalf of IAP Trivandrum and Kerala, I thank the presenter, case presenter, Dr. Arun Keshan, who had done a wonderful job in presenting, as Susan Madam had said. He had done the work very meticulously and answered all the questions very aptly. And next, I would like to thank our beloved chairperson, Susa Uthup Madam, for taking the session in a very interesting and very interactive manner. And special thanks to the mentor, Dr. Christy Catherine Thomas. Thank you, Madam, for mentoring the case. And next, I would like to thank Mohandas sir for carrying this flagship program, that is PG teaching program, very meticulously throughout this year. And this program is not only very important for all the postgraduates, but also for the practicing pediatricians, and very valid points have been discussed today. And thank our State President Shimi sir, our State Secretary Krishnamohan sir, our academic scientific convener Ananda Keshwan sir, and our IAP TV Trivandrum coordinator PG teaching, Dr. Priya Srinivasan, and rest of and there were also valuable inputs from Srinivasan sir and Purushothaman sir. Thank you, sir. And last but definitely not the least, I would like to thank all our audience for the patient listening and for their valuable inputs. Thank you all once again.
Good night.
Thank you.
Thank you, sir. Thank you, madam.
Good night, all of you. A very nice case, and a lot of learning points were there. Of course, each and every case presented is wonderful. And thank you so much. I am benefited very much.
Sir. Thank you, sir.